Welcome to StudyNeuro. This session, titled Comprehensive Guide to Higher Cortical Function Assessment, provides a clear, structured overview of how higher cortical functions are evaluated as part of the neurological examination. We will walk through a systematic bedside approach to assessing orientation, attention, language, memory, gnosis, praxis, calculation, abstract thinking, judgment, and visuospatial skills, highlighting their clinical relevance for lesion localization and diagnosis. By the end of this lecture, you should be able to define the key domains of higher cortical function, perform a stepwise assessment from basic to complex functions, and confidently interpret findings to distinguish focal cortical deficits from diffuse cerebral dysfunction. Assessment of higher cortical functions is a core component of the neurological examination and provides crucial insight into how the brain is working at a cognitive level. Before beginning, it is essential to confirm that the patient is alert and able to cooperate, which is why the level of consciousness should first be assessed using the Glasgow Coma Scale. Once this is established, higher cortical function testing allows the clinician to evaluate key domains such as cognition, memory, language, attention, executive function, calculation, and visuospatial skills. This assessment has significant clinical value as it helps localize neurological lesions, identify cognitive impairment in conditions like stroke, dementia, and head injury, track disease progression in response to treatment, and ultimately guide appropriate patient management. When assessing higher cortical functions, the first priority is to establish the patient's level of consciousness. If alertness is impaired, more detailed cognitive testing may not be reliable, so this must be clarified before proceeding. The assessment should then follow a logical, stepwise approach, moving from simpler functions to more complex ones. Throughout the examination, careful observation is just as important as formal testing. How the patient pays attention, cooperates, and responds emotionally often provides valuable clues about underlying cognitive function. Testing should always be adapted to the patient's cultural background, language, and level of education to avoid misinterpreting normal variations as pathology. Rather than viewing each domain in isolation, findings must be integrated across language, memory, attention, praxis, gnosia, and visuospatial abilities to identify meaningful patterns. It is also important to repeat tasks and confirm abnormal responses. This helps distinguish true cognitive deficits from temporary factors such as fatigue, anxiety, or poor concentration. Finally, the overall pattern of abnormalities should be correlated with likely areas of brain involvement, allowing the examiner to move from bedside findings toward accurate anatomical localization. Orientation reflects a person's awareness of time, place, and person, indicating how well their internal understanding aligns with the external world. It is a key marker of global cerebral function. Clinically, impaired orientation suggests diffuse brain dysfunction, commonly seen in delirium, dementia, and metabolic encephalopathy. Because orientation relies on both hemispheres, the reticular activating system and association cortices, focal lesions rarely cause isolated disorientation. Disorientation typically follows a hierarchy, with time affected first, then place, and person last. Orientation is assessed across 3 domains. Time orientation is evaluated by asking questions such as the day of the week or time of day. Place orientation is assessed by asking where the patient is, for example, which hospital or city they are in. Person orientation is assessed by confirming identity and relationships, such as asking the patient their name or who is with them. Attention is a fundamental cognitive skill that allows us to focus, process information, and carry out complex tasks. It's what keeps our perception, memory, and decision-making on track. The brain handles attention through several networks. the dorsal attention network helps us direct our focus intentionally, like choosing to read a book in a noisy room. In contrast, the ventral attention network responds reflexively to unexpected events, such as turning toward a sudden sound. Attention itself has different forms. Sustained attention lets us maintain focus over time, while selective attention allows us to concentrate on one thing amidst distractions. We also need alternating attention to switch between tasks, and divided attention to manage multiple things at once. The right hemisphere plays a particularly important role, especially in vigilance and spatial awareness. Damage to the right parietal lobe can lead to neglect of the opposite side of space. Subcortical structures like the thalamus, basal ganglia, and the reticular activating system regulate alertness and arousal. Clinically, attention deficits can appear as inattention, distractibility, neglect, or repetitive behaviors. We often assess these abilities using tasks like digit spans, cancellation exercises, or dual task paradigms to see how well patients can focus, shift, and divide their attention. Assessing attention involves several simple but informative tasks. Digit span tests basic focus and working memory, with the backward version engaging the frontal lobes. Cancellation tasks and line bisection assess spatial attention. Missing items or consistent line deviations often point to right parietal lesions. Serial 7s measure sustained attention and calculation, with frequent errors suggesting inattention or frontal dysfunction. Dual task tests, like walking while performing a mental task, reveal difficulties in dividing attention, implicating frontal subcortical networks. Together, these tests help pinpoint both the type and location of attentional deficits. Language is one of the key higher cortical functions we assess during the neurological examination. In most right-handed individuals, it is mainly controlled by the left hemisphere, although it relies on several brain regions working together rather than a single center. For example, one area is responsible for producing speech, another for understanding spoken language, and connecting pathways allow these regions to communicate efficiently. Speaking fluently is not just about moving the mouth. It requires coordination between cognitive processes like understanding words and grammar and motor processes that control articulation. Because language is complex, it cannot be evaluated with a single question. A proper assessment looks at multiple skills, including how fluent speech is, whether the patient understands commands, can name objects, repeat phrases, and read or write when appropriate. Finally, it's important to remember that language performance is shaped by factors such as age, education, cultural background, and multilingual ability. These must always be considered to avoid misinterpreting normal variation as pathology. When assessing language, we evaluate several complementary skills to understand how well different language networks are functioning. We usually begin with fluency. For example, we may ask the patient to name as many animals as possible in 1 minute. This task provides quick insight into word generation, speech flow, and executive control. Picture description can also be used, where the patient explains what is happening in a simple scene to assess sentence structure and coherence. Next, we assess auditory comprehension by giving spoken instructions of increasing complexity, such as asking the patient to raise their right hand and then touch their left ear. This helps determine how well spoken language is understood. Naming is then evaluated by showing the patient a common object, like a pen, and asking them to identify it. Difficulty with this task may indicate word finding or lexical access problems. Repetition examines the link between understanding and speech production. A simple sentence, such as, "The cat sat on the mat," can be used,
and errors can suggest disruption of language connections. For reading, the patient may be asked to read a short sentence aloud, such as, "The sun rises in the east," and then explain what it means. This helps separate decoding problems from comprehension deficits. Finally, writing is assessed by asking the patient to write a simple sentence about their day. This allows evaluation of spelling, grammar, syntax, and written expression.
Memory is a complex process that involves multiple brain regions, including the hippocampus, medial temporal lobe, neocortex, amygdala, and subcortical structures. It isn't just one ability. It spans several domains, from short-term and working memory to long-term memory, which includes both declarative memories like facts and personal experiences and non-declarative or procedural memories, such as learned skills. Memory happens in stages, encoding new information, consolidating it into long-term storage, and retrieving it when needed. The hippocampus plays a central role in forming new memories, so damage here can lead to difficulty creating new memories, while older memories often remain intact. Memory is influenced by attention, emotions, and executive function. For example, if attention is impaired, encoding suffers, whereas emotional experiences tend to be remembered more vividly. Different patterns of memory loss can suggest specific brain disorders. Episodic memory problems are common in Alzheimer's disease, procedural memory deficits in Parkinson's disease, and working memory deficits with frontal lobe lesions. To assess memory, clinicians use a combination of tests, such as immediate and delayed recall, recognition tasks, and procedural tasks, often employing tools like the Mini Mental State Examination, the Montreal Cognitive Assessment, or the Wechsler Memory Scale to get a comprehensive view. Memory comes in different types, each linked to specific brain regions. Working memory, managed by the dorsolateral prefrontal cortex, lets us hold and manipulate information briefly, such as repeating digits forward or backward. Short-term memory relies on the hippocampus and medial temporal lobe, allowing recall of items over minutes. Difficulty here often reflects encoding problems. Long-term memory includes episodic memory, personal events dependent on the hippocampus and prefrontal cortex, semantic memory, facts and knowledge linked to the lateral temporal cortex, and procedural memory, skills like tying shoelaces, involving the basal ganglia and cerebellum. Deficits in each type point to dysfunction in the corresponding brain circuits. When evaluating memory, it's important to distinguish between recall and recognition. Recall refers to retrieving information without any hints or prompts. For example, you might ask a patient to repeat the 3 words you just told them or to describe what they had for breakfast. Difficulty with recall can indicate a problem with encoding or retrieving the memory. Recognition, on the other hand, provides cues to help the patient identify previously learned information. For instance, you could show a list of words and ask which ones were mentioned earlier. If a patient struggles with recall but can recognize the correct items, this usually points to a retrieval issue. However, if both recall and recognition are impaired, it suggests a deeper problem with encoding or storing the memory. When assessing memory, it's important to adjust tasks to the patient's estimated cognitive level, making sure questions are culturally and age-appropriate. A thorough assessment should test both verbal and nonverbal memory and look at recall immediately and after a delay. As the patient performs the tasks, watch for common memory errors. Intrusions occur when a person adds words or details that were not presented. Perseveration is the repetition of a word or action beyond what is required. Confabulation happens when someone fills in gaps in memory with fabricated but confident statements. Inconsistency refers to giving different answers to the same question at different times. For verbal memory, a typical test is presenting a few unrelated words from different categories. You track how many trials it takes for the patient to learn the words, then test immediate and delayed recall after several minutes. If recall is incomplete, category cues or recognition lists can help. Poor recall with intact recognition usually indicates a retrieval problem, while poor recall with poor recognition may suggest a storage or encoding deficit. Gnosia is the brain's ability to recognize objects, people, sounds, or sensations despite intact sensory input. Patients with anosia can see, hear, or feel normally, but cannot interpret what they perceive. Visual recognition relies on the occipital temporal pathway, auditory on the superior temporal gyrus, tactile on parietal association cortex, and face recognition on the fusiform face area of the right temporal lobe. The right hemisphere supports faces, visual spatial processing, and navigation, while the left handles language and symbols. Clinically, always confirm intact sensation and use culturally familiar stimuli. Modality-specific deficits help localize lesions and guide strategies for daily functioning and safety. At the bedside, assessing nausea involves testing the patient's ability to recognize familiar stimuli across different senses. For visual agnosia, you present common objects such as a pen, key, cup, or phone, and ask the patient to identify them. A patient with visual agnosia may describe the shape or color, but cannot name or explain the object. In auditory agnosia, familiar environmental sounds like a doorbell or phone ring are played. The patient can hear normally, but cannot identify the source of the sound. Tactile agnosia, or asteragnosis, is assessed by placing everyday objects, like a coin, key, or comb, into the patient's hand while their eyes are closed. The patient may feel the object, but cannot recognize it by touch. Finally, prosopagnosia involves showing photographs of family members, colleagues, or familiar local figures and asking if the patient recognizes them. Affected individuals may fail to identify familiar faces, but might recognize them by voice or contextual cues. These simple bedside tasks provide valuable insight into modality-specific recognition deficits and help localize cortical dysfunction. Praxis is the ability to plan and execute learned, purposeful movements and depends on intact motor strength, sensation, coordination, and comprehension. It is mediated by the dominant inferior parietal lobule, which stores motor programs, the premotor and supplementary motor areas that translate plans into action, and the corpus callosum for interhemispheric transfer. Apraxia represents a motor planning deficit rather than weakness or ataxia and has major functional implications for tool use and daily activities. Lesion patterns aid localization. Left parietal lesions cause bilateral limb apraxia, corpus callosum lesions affect the left hand, and right parietal damage leads to constructional apraxia. Apraxia is common in stroke and neurodegenerative disorders and can severely limit independence despite preserved strength. At the bedside, ideomotor apraxia is identified when a patient understands a command but cannot correctly perform a learned gesture, such as waving goodbye or pretending to brush their teeth. Movements are often awkward or incorrect, yet performance may improve when the actual object is used, indicating a motor planning deficit. Ideational apraxia is characterized by impaired sequencing of multi-step actions. When asked to demonstrate tasks like making tea or lighting a kerosene stove, patients perform steps out of order or misuse objects despite intact strength and comprehension, reflecting a breakdown in the organization of complex actions. Constructional apraxia refers to difficulty constructing or copying visual spatial forms despite intact vision and motor strength. At the bedside, this is assessed by asking the patient to copy intersecting pentagons, draw a clock with correctly placed numbers and hands, or arrange matchsticks to form simple shapes such as a square or a house. Typical errors include distorted spatial relationships, poor overall organization, or neglect of one side of the figure, findings that are often associated with right parietal lobe dysfunction. Limb kinetic apraxia, in contrast, involves a loss of fine, precise movements of the distal limbs. Patients may struggle with tasks requiring dexterity, such as rapid finger tapping, buttoning a shirt, tying a knot, or picking up small coins or beads. The movements appear slow, clumsy, and imprecise, even though strength, sensation, and coordination are otherwise preserved. Calculation is an important higher cortical function involving the parietal lobe, attention, working memory, and executive skills. Simple arithmetic like addition or multiplication and more complex multi-step problems rely on these networks. When calculation is impaired, called a calculia, it may result from isolated parietal damage or secondary to deficits in language, memory, or visuospatial skills. Left parietal lesions can cause Gerstmann syndrome, including finger agnosia, right-left confusion, agraphia, and acalculia, while right parietal damage may affect estimation or spatial calculations. Assessment can be verbal, written, or practical, such as solving arithmetic problems, counting money, or measuring ingredients, allowing clinicians to evaluate both calculation and the supporting cognitive processes. The serial subtraction test is a quick bedside tool to assess working memory, attention, and calculation. Patients subtract a fixed number repeatedly, such as 7 from 100 or 3 from 20. Accuracy and speed reflect calculation ability, while errors may indicate frontal or parietal dysfunction or deficits in attention. Its simplicity allows it to be easily scaled for age or education level, making it practical for routine neurological assessment. Abstract thinking is our ability to go beyond the literal and consider concepts, ideas, and hypothetical situations. It underlies problem solving, planning, and understanding metaphors or complex relationships. This function relies heavily on the dorsolateral prefrontal cortex and integrates information from the parietal and temporal association areas. It also depends on attention, working memory, language comprehension, and executive function. In daily life, abstract thinking allows us to make decisions, reason socially, and adapt to new situations. When impaired, people may struggle with planning, professional tasks, or understanding indirect meanings. Clinically, we can assess abstract thinking by asking patients to interpret proverbs, identify similarities between objects, or solve hypothetical problems. For example, questions like, how are an apple and an orange alike? Or, if water is spilling from a tap and a mop is nearby, what would you do? Reveal their ability to reason beyond the obvious. Frontal lobe damage often leads to concrete thinking, where patients interpret everything literally and have difficulty identifying patterns or relationships. Judgment is the ability to make safe and socially appropriate decisions, anticipate consequences, and choose the best course of action in real-life situations. It's not just about knowing facts or being intelligent. Someone can have intact memory and language, but still make poor decisions if judgment is impaired. The prefrontal cortex plays a central role in this process. The orbital frontal cortex helps regulate social behavior, control impulses, and evaluate risks. The ventral medial prefrontal cortex integrates emotion and reasoning to guide value-based decisions. Meanwhile, the dorsolateral prefrontal cortex supports planning, foresight, and weighing alternatives. Because judgment relies on these frontal lobe networks, it is particularly vulnerable in conditions that affect the frontal lobes, and deficits can have significant impacts on daily life, social interactions, and safety.
Clinical assessment of judgment is best done using practical, real-world scenarios rather than abstract questions. For example, a clinician might ask what someone would do if they entered a room with water flooding from a running tap, or if they smelled gas or petrol fumes in their house. Another scenario could involve a child playing near a busy road, asking the person how they would respond. The way a person answers these questions can reveal which parts of the prefrontal cortex may be affected. Impulsive or risky choices often point to orbital frontal cortex dysfunction. Difficulty planning or foreseeing consequences suggests problems in the dorsolateral prefrontal cortex, while emotionally inappropriate responses may indicate ventral medial prefrontal cortex involvement. Judgment is critical for daily life. Impairments can lead to unsafe behaviors, financial mismanagement, poor adherence to medical advice, and loss of independence. Assessing judgment in realistic scenarios helps identify these risks and guides appropriate intervention. Visuospatial function refers to the brain's ability to perceive, integrate, and interpret visual information in space. This capacity allows us to orient ourselves, navigate our environment, and perform actions guided by what we see, such as reaching for objects or judging distances. The primary neural substrate for visuospatial processing is the right or non-dominant parietal lobe. This region is especially important for spatial awareness, attention to the environment, and understanding the overall or global visual scene. Visuospatial processing relies heavily on the dorsal visual stream, often called the where or how pathway. This pathway runs from the occipital cortex to the parietal cortex and is responsible for analyzing motion, spatial location, and the relationships between objects in space. Importantly, visuospatial function does not operate in isolation. It is integrated with the frontal eye fields to control eye movements, the premotor cortex to support visually guided actions, and executive networks that enable spatial planning and navigation. Together, this distributed network allows seamless interaction with the visual world. Visuospatial dysfunction presents with characteristic clinical patterns, such as hemispatial neglect, most commonly left-sided neglect from right parietal lesions, constructional apraxia with impaired figure copying, topographical disorientation affecting navigation, and balance syndrome from bilateral parietal damage. Assessment is largely nonverbal and includes figure copying, clock drawing, line bisection, cancellation tasks, and simple navigation questions. Errors on these tasks usually reflect impaired spatial attention and integration rather than primary visual loss, making them valuable for localizing parietal lobe dysfunction. As you conclude the examination, it is important to bring everything together in a clear and reassuring way. Begin by briefly summarizing the key findings for the patient, confirming both your own understanding and helping the patient recognize any difficulties that were identified during the assessment. Next, explain the clinical significance of these findings. Discuss the most likely causes of the observed deficits using simple, patient-appropriate language rather than technical terms. This helps the patient understand what the results mean without causing unnecessary anxiety. Accurate documentation is essential at this stage. Record the pattern of deficits carefully, as this can help with anatomical localization. Consider whether the presentation suggests an acute or chronic process, and relate your findings to available neuroimaging and laboratory results. Finally, outline the next steps clearly. Let the patient know if further tests are needed, discuss possible treatment or management plans, and set expectations for follow-up. A well-structured closing not only completes the examination, but also improves patient understanding, builds trust, and encourages engagement in ongoing care. In summary, examining higher cortical functions is a vital part of a complete neurological assessment. It brings together careful observation with simple commands, imitation, and practical bedside tasks to build a clear picture of how the brain is functioning. This approach helps clinicians localize cortical lesions, identify cognitive deficits early, and make informed decisions about diagnosis and management. To be most effective, bedside assessment should be carried out in a structured way, tailored to the patient's cultural and educational background. Thanks for watching. Don't forget to like, share, and subscribe to StudyNeuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.